Oh, didn't see you there. I'm Dr. Wiseman, also known as Dr. Wise Guy, and welcome to my YouTube channel. Today we're going to be talking about something that's not so fun. But why not? Because we're talking about death, silly. Oh. So today we're going to discuss end-of-life decisions and what you and your family need to know to be prepared. But first, as always, some disclaimers.
Everything on this video is my own opinion and does not represent the opinions of any organization, whether it be a hospital organization or national. Also, everything on this video is strictly an opinion and cannot be presented as specific medical advice. If you have any specific medical condition or need advice, please consult your doctor and do not consult me.
I think it's really important that we as Americans and we as humans embrace the idea of life and death. We have to accept the fact that everybody's here is going to die. Me, as a physician, I deal with life and death all the time. It is not uncommon for me to deal with somebody as they're dying and then the grief that surrounded them by their family members and everything going on. It's a hard time, but something that we deal with on a regular basis. What I see, what kills me the most, is when you have family members who don't know what to do, who are stuck with these decisions because they don't know the wishes of their family member and are trying to do the best thing. I encourage you to talk with your pastor, your priest, your religious leader, talk with your family, have a real conversation about how you want to die and what you want to happen if and when you die. I shouldn't say if, when you die. We're all going to die. I know what I want. I've had those conversations with my family. That's a personal decision to me. It's a personal decision for you. It's a really important topic, especially in the current climate. Don't be afraid of it. It's real. It's human. It's what makes us human. So be part of it. This is about understanding what you need to know when you or a loved one is dying and what the process is that will go through. Also, you need to know what decisions you need to have made ahead of time so that doctors can appropriately assess you, treat you, and do what's best for you. So today, what I want to do is I want to talk about one of the more taboo topics in healthcare. This, in my opinion, is something that's important for everybody to know, but now specifically with the coronavirus pandemic going around, it's more important than ever for people to be aware what their rights are, what their options are, and to have these conversations with their family members and their loved ones. The current coronavirus pandemic has opened up this big conversation about what to do in certain cases. We're currently looking at problems where people that are over a certain age might not be given the life-saving treatment that they would have before this pandemic. This means people are going to have to be presented with pretty severe and hard to swallow decisions on end of life. That also means people are going to be presented with life and death options. We have to be realistic and say that as human beings, part of our expected course of life is death. And we need to know how to deal with that should that time come. This is something that I have dealt with a lot in the emergency department and in my training. It's something I'm particularly passionate about, and I think the more we can spread this awareness and have better people better prepared, the more knowledge is going to be out there and the smoother the transition is going to be. All right, so I want to start off by explaining a few terms that you might hear should this conversation arise, and is pretty common to us in the medical field. So there are 5 essential stages. Now this is a rough estimate. Essential stages when it comes to end-of-life decision-making. First is normal. Second is DNI. Third is DNR. Fourth is comfort care. And then we're going to talk a little bit about hospice care. All right, so the first one we talked about is easy. Normal is normal. That means should you come to the emergency department, you're unconscious, you're dying, anywhere in the hospital, we're going to do everything we can to save you. You have to understand what this means. So if your heart were to stop, this means we're going to start chest compressions and CPR. Good chest compressions, good ones, require us to break the ribs in the front so that we can open things up, push down on your heart to basically do the job of the heart for it. Basically pushing down on the heart, circulating that blood so it can get to your organs, getting the oxygen that it needs. The other thing that routinely happens during this, if you're dying or some end-of-life thing is going to happen, is we're going to put you on life support. Life support can mean a few different things, but the basics are what we're going to do is we're going to intubate you. So intubating is when we put a plastic tube that goes into your throat, down into your windpipe. This gets connected to a ventilator, and that ventilator controls your breathing and basically does your breathing for you. Now, there are a couple other measures. There are things like central lines, IV lines, and then a number of other stickies, procedures, things like that, which can arise depending on your specific condition. If you come in and you have no advance directive and no wishes, We're going to do all this and assume that you want everything done to save your life. What I consider the next level is something called DNI, or do not intubate. This simply means that if you come in and you're sick and dying, we're going to do everything but put a breathing tube in. So this avoids you being put on a ventilator. A lot of times I see this in patients who are either cancer patients or have other chronic or end-of-life conditions, see ALS or Lou Gehrig's disease. And these people know that they might be dying soon, hate the idea of having a breathing tube in, which can be somewhat uncomfortable, and say, you can do everything else, but I do not want to put a breathing tube in, no questions asked. The next level up from that is something we call DNR. So DNR is a do not resuscitate order. This means if you come in and your heart were to stop, we would not do CPR, we would not instigate extreme measures to bring you back. Now, a common misconception, both between lay people and doctors, is that this could mean do not treat. That is not the case. If you come in and you're a DNR and you have a broken toe, a little bit of pneumonia, urinary tract infection, we're still going to treat you, and we're going to treat you as normal. We can even give you some of the life-saving measures, including IV antibiotics and pressors. It just means that if your heart were to stop, we will not do anything we can to try and bring that back. The next level above that, below that, whatever you want to say, is what I call, what a lot of people call comfort care or comfort measures. So this is if you've gotten to the point where some of these things are instituted partially, but we've decided that we don't want to do any of this stuff. IV antibiotics aren't going to help anymore. Some of those medications to bring your blood pressure up aren't doing anything. We essentially, either your family says don't do anything, or we don't think that you're going to make it, and none of that stuff is going to help. And so what we do is we shift our focus to making you comfortable. This means anti-anxiety medications, pain medications, basically focusing on, we think you're going to die. Death is a natural part of life, and we want to try and help that and not prolong your suffering in that case. So the last thing I want to talk about is something called hospice care. So hospice care actually encompasses a wide range of treatments and facilities, which are usually focused on end-of-life or terminal conditions. Say you have cancer, we don't think it's treatable anymore, and you want to focus on being comfortable in the end stages of life. That's what hospice focuses on. One of the common things that I see, and people get misconstrued with this as well, is they feel like hospice means we're not going to treat any of the minor things, which also isn't true. For minor conditions, if you have a little bit of pneumonia or something that's not related to your primary condition, you can come to the emergency department, you can come to the hospital, get fully treated like anybody else. So it doesn't mean you're going to be put in the back burner, no one's going to care, no one's going to treat you. They're going to treat you like a normal person. We're just going to focus more on making sure you're comfortable, helping your family out, and giving you resources at the end of your life, which I think is very reasonable. All right, so now we've gotten through those basic concepts and terms. So the question is for you, when are we going to decide to be DNR, DNI? When are we going to choose those things? This is a complicated question. Take it seriously and think about it. This is something you really need to decide for yourself. If you're young and healthy, in all likelihood, you want us to do everything we can to save you. There's a good chance you're going to bounce back. Depends on what the situation is, but you can endure it and you can bounce back. If you're on the older side, you have a lot of comorbidities, you have a lot of other conditions, maybe you have cancer, maybe you want to consider something like DNR, DNI. This is a very personal decision. You need to involve your family, anything with faith, your personal experiences. All of that combined needs to dictate what you want to do, but you have to have a real conversation with yourself and your loved ones to decide what's the best thing for you. The last person you might actually want to get involved in this, you might actually not think about, is your lawyer. Why do lawyers have to get involved? Oh my God, why are you talking about lawyers? The reason I'm talking about lawyers is sometimes they can help you designate a person. So you have to understand, most of the time, if you come into the hospital and you're actually dying, you don't have the ability to make a decision for yourself. That means that the decision is going to lie or is going to rest upon what's designated as your medical decision maker. Now, there are a few ways that go through this, and there's actually a hierarchy, so we're going to walk our way down through this. Number one, this becomes a person that you have designated by law to be your medical decision maker. Now, this is not necessarily the same as your power of attorney. You can designate someone to be your power of attorney, which means that they can make legal decisions for you, but you have to specifically state that they're going to be your medical decision maker. This can be anybody. This can be your best friend. This can be your pool boy, Karen, or it can be anybody that you designate. This person has to be designated before the event by a lawyer or through a lawyer through the legal system. Number 2, this is a court-appointed medical decision maker. This usually only occurs with someone who has no other friends or family that can make a decision for them, in which time the court actually appoints somebody to make medical decisions for them based on their best information. Number 3 is their spouse. So anybody that you've been married to. Common law usually does not apply, but the other thing to be aware of, and I've run into this in the ICU in the emergency department, people think, oh, well, they're married, but they haven't spoken in 7 years. It does not matter. If you have a spouse and you are not divorced, technically that person makes decisions for you. That person makes your medical decisions when you're lying in a hospital bed dying. Keep that in mind. After that is number 4. That's adult children. Those are children that are over the age of 18 that can make decisions. Now, when it comes to children or multiple people, they have to reach a majority rules vote. It doesn't have to be unanimous, it has to be majority rules. So that means if there's 3 children, 2 of the 3 have to agree. If there's only 1, you're in luck, it's just the 1. Following this are your parents. They come after children. Obviously, that's pretty straightforward. After parents are your siblings, so living siblings. Also, that's ruled by a majority rules vote. And then finally, any other relatives. So remember, if you do appoint a medical decision maker, they can supersede all of this stuff. In fact, they also supersede your advanced directives, which we'll talk about in a little bit. I encourage everybody to be vocal with their entire family about their wishes. Sometimes there can be confusion. We as doctors, we take an oath to do no harm, which means we're going to try and do the best thing to try and fit with your wishes based on all the information that we have. This means the more people that know, the more people that can inform us, the better. We do at some circumstances have the ability to intervene if we think somebody is acting that's not in your best wishes, but we need to know that information. All right, so what is an advance directive? So this ends up being a legal document in which you state exactly what you want done. This is usually done in front of a witness and a lawyer and says, hey, I want this amount of intervention. If I'm on a ventilator, I only want to be on for 2 weeks. If I come in, I don't want anything done. So this advance directive is really useful. What you need to realize is that in most states, your medical decision maker, that could be your estranged spouse, they have authority over your advance directive. I know this seems kind of crazy. You have it written out what you want, but that medical decision maker says, well, they did that advance directive 2 weeks ago, but yesterday they told me that they want everything done. That supersedes it. So you have to be mindful. It's more important regarding the conversations you have with your family and those people and making sure you trust them to do what's in your best interest. The other downside with advance directives is they're a piece of paper. Say you come to the emergency department and you come in for a car accident. Well, you probably don't have that piece of paper on you. I won't be able to know what your wishes are. I have to go based on your family when I call them up and say, hey, this person's in the hospital. Do you want us to do everything? This video is a big topic and it's running a little bit longer than I like. So I am going to do a follow-up video talking about things to expect in the ICU, when to have good prognosis, when not to. But this conversation is basic information, well, a little bit more detailed about the things you can expect should you enter end-of-life discussions. Once again, welcome for joining my channel. I hope you enjoyed it. I hope it was entertaining and informative. If you like it, please like and share. Get this information out. It's not something everybody hears, and I want people to be informed. As always, I love you. Go out there and do no harm.